Hello, everyone, and welcome to UroNurse. We meet live every Saturday at 9 a.m. Central Daylight Time. My name is Vic Sinise, and I'm the host for today's show. If you're watching this on YouTube, you can learn more about us by visiting our website at UroNurse.com. Now, our first half hour will be devoted to general questions, and our second half hour, we're going to take a deeper dive into a subject. Today's subject is going to be BPH treatment in the office. We're happy to have Dr. Herbert User to present on the Rezum and Urolift procedures. To submit a question, simply click the Q&A button and type in your question. And I'm going to take it away and let Lori introduce herself real quick here. There we go. Lori, go ahead.
Hi, I'm Lori Atkinson. I've been in urology for 24 years. I currently work at Northwestern in Illinois at, at Delmore in Geneva. And I've been a certified nurse, certified urology nurse since 2003.
Okay, very good. So we're going to start off the day a little different than we have in the past. Now, this is something that I encourage people to do. If there's something that you hear at one of our meetings and suddenly, you say, oh, I wish I would have asked that question, just send it to us. There's a questions and answer spot to go ahead and send that. And I'm going to go ahead and read this off for you right now. Let's see. I got to do one thing quickly here. Otherwise, I can't see it. So this came in. Hello, Vic. This is a question about our last discussion. So I hope it's okay to ask some clarity on office anesthesia. Again, always good to send us a question. In today's discussion, they attended that last week, you presented research showing how lidocaine glidogel is more effective in pain management if used almost immediately, as opposed to waiting up to 10 minutes for the lidocaine and sterile water mixture. Also, your research showed a wait time of 6 minutes for best results. At least that's how I remembered your explanation of the research. And I presented a couple different things, so that's probably part of the confusion. In the SUNA Urologic Nursing Core Curriculum, first edition, it says to be, and I quote, to be beneficial, the lubricant, 2% lidocaine gel, should be indwelling in the urethra at least 15 minutes. And she gives that page for the curriculum. I was glad to hear about the almost immediate use of glidogel pre-procedure, but this complicates things a little. Can you please clarify regarding your research from today and the textbook information? Thank you for this resource, Vic. I really appreciate your Saturday mornings. Great question. A lot of good things there. Let's tackle a few of those. So in my discussion, I had said that there was a lot of debate over all this. So I think it helps if we talk a little bit about what type of evidence there is when you're looking at research papers. And they divided into 3 grades, grade A, B, and C. Now, grade A is what you really would like to find. That means you have high quality evidence, a well-conducted randomized clinical trial, and exceptional, strong observational studies. That would be the best thing in the world. Grade B is not bad, moderate quality evidence. You have some randomized controlled trials with some weakness, generally strong observational studies. Grade C, low quality evidence, observational studies that provide conflicting information or design problems such as small sample size. Kind of remember that last one, C. Also, that's a thing that is allowed in research is expert opinion. Now, expert opinion is a statement achieved by a panel consensus that is based on members' clinical training, experience, knowledge, and judgment, and for which there are no published evidence. And then there's clinical principle, a statement about a component of clinical care that is widely agreed upon by urologists or other clinicians, and for which there may or may not be evidence in the medical literature. Now, we go to our article that was the one that she was referring to that I presented, and that was the lidocaine gel. And what it basically stated was looking at the gel versus a liquid mixture. They did a study of 10 minutes and immediate. And with the gel, the immediate worked better. And that's kind of where I was taking my evidence. I also used some clinical judgment in the fact that I personally had some dental work done with lidocaine, gums being a mucous membrane, very similar to urethra, and could tell you that it worked immediately for me. Also, I've done a lot of catheters in my experience with it, and I have used it immediately, and patients seem to have plenty of comfort with it. But with that said, that study was only 147 patients, far from a big randomized clinical trial. At best, it's probably grade C or low quality evidence. And if you do a lot of research, you'll find there's many papers that have conflicting reports, such as this one where they looked at, and this may be the one that they were quoting in the manual, 400 in the study, and they concluded 15 minutes of dwell time was ideal. So very similar to what you read in the manual. And again, there's a article back from 1994 in the journal Urology that supports that it doesn't even work. Lidocaine gel versus regular gel, there's no difference. So the bottom line is as you kind of read through all these, you're going to be able to find stuff that supports you and stuff that doesn't support you. And that's where your clinical judgment comes in. This is another article that I found where I thought it was interesting. They did 2 studies and looked at immediate versus a 2-minute delay, and really didn't see any significant difference between the immediate use in 2 minutes. And obviously it's not the 15 minutes, but the point is there's a lot of studies out there. However, they conflict with each other. I can't find, or didn't find, at least in my research, any big, large randomized clinical trial that would support either one of those. So what do? Where are you left? Well, you're left with expert opinion and clinical principle, or at the very least, you're using some grade C evidence. And that's basically where I kind of left things last week. And hopefully it's a good explanation to why I stated what I stated based on my own judgment and based on the research I did, and why there's a conflict, and why you might say, well, this is what it says in the journal. I mean, isn't that the most up-to-date information? Well, actually that book, by the way, is I think undergoing its 2nd or 3rd edition now. So books are always several years in, it takes years to make a book. So the data that by the time they go to press is probably 2-3 years old. That's why they have to go and update them. So yeah, at best, I can't argue it, but I can argue against it too. I can't prove it. So anyway, I hope that answered your questions. And if you have any other questions, please feel free to go ahead and submit your questions. This is your time. I'm looking at the Q&A box to see if anybody has any questions, comments, concerns. It's a beautiful day today. I know it's Labor Day weekend. I wasn't expecting a huge audience. I'm glad to see all of you that have shown up. It's great. We do record this, and that's part of the beauty, is that even if it doesn't have a big audience today, the future audiences will be there. I will throw something out here. If anybody in the audience feels they would like to be a panelist, you can always volunteer to be a panelist by submitting the form on our website. But today I'll make the unique opportunity. If anybody wants to be a panelist, send that in the Q&A. Hey, promote me to panelist. I'll be glad to move you over to the panel from the attendees. It's your opportunity if you want to say something. And if not, you're enjoying sitting back, that's perfectly fine, because that's what we built this for. We've had some of you that have shown up for the after party. And what do you think, Lori? How's the after party going?
I love the after party because you could just let it loose. You can ask anything you want. It's just laid back, and you can, excuse me, you can just ask anything you want.
I kind of think it's like when you go to the meeting, and after the end of the talk, everybody kind of mills around outside the room, and what did you think about what he said? Or you kind of ask these other questions, or you find that speaker and you didn't really want to put your hand up because you didn't want to look like an idiot, which nobody looks like an idiot, but
no.
You always think that, right? And so anyway, you go out in the hallway and you say, hey, by the way, what do you mean by this? Or what did you say there? And it's
a great way to get to know people. The
Yeah.
last after party was great. We got to know some people in other states. It was great.
Yeah. So it is. And This format is far from written. We're learning every time we do something. We're trying something a little different. So again, whatever you want to see, let us know. If we're doing something good, let us know. If we're doing something you don't like, let us know. I toyed around with at the beginning whether we should banter with each other and have that off screen, because we can do that, or have it on screen. And wow, everybody said, hey, we like what you're talking about. So we're leaving that as part of the show now. I do cut it out of the pre-recorded, the ones that you watch on demand. Those are more just watch the program. But I think for those that want to join live, hey, it's fun. Let's continue that. And anybody that's in the audience that wants to join that after party, just go to the website, UroNurse.com, and click that big red button that says after party. We'll love to hang out with you. Now, if we don't have any questions, do you have anything that you wanted to talk about, Lori? I don't see any questions yet. People might be thinking over what they want to say.
I actually do. And this came up this past week because the BCG shortage is a reality to our office right now. And we've been okay so far. But now one of our doctors presented, from the AUA that 1/3 BCG is appropriate. And so I just wanted everybody's opinion on that, because, we may have to do that because we are really short now. And I just wanted others' opinions on that.
Yeah. Anybody that has an opinion, feel free to just throw that into the Q&A and I'll read it off. We've been using 1/3 BCG in the past for patients that have had issues with tolerance. So sometimes full strength BCG, they come back and they're like, man, I've got terrible urinary frequency after that. And you're debating whether you should continue it or not. So there's a protocol out there that supported that. I can't remember the study, but anyway, so we cut it down to 1/3 and found that a lot of patients could tolerate the lower dosages and did fine. So I think there's some rationale.
The question to you, Vic, is that, so if you do the 1/3, do you have other patients so you don't waste the whole vial?
That would be ideal, especially right now, because we don't want to be wasting it. So I think it's a scheduling situation. Back in the past, I have to tell you, it was just wasted. You had to document that you're wasting it too. That was important because of charging, for charges on that. That'd be a great one to ask John Lynn if he
for sure
when he joins us, because he's done a lot of stuff with billing. I know that there's some codes that you're supposed to do when you have to waste something, so that you can be reimbursed.
We just don't want to waste it, because we're probably doing 8 to 10 BCGs a week, and we're down to like 24 vials. And it's, the allocation for our office is only 2 per week, and the pharmacy gets an allocation. Yeah, it's bad. And the allocation for the pharmacy was 6, dropped to 3 because they just don't have it. And so it's getting really difficult to get it for our patients.
Yeah. So in that case, definitely, the 1/3 would be better than not being able to treat somebody, I think. But I think definitely we need to get an expert to try to talk a little bit about that. I know Chicago Metro had a Zoom meeting where we brought that to, let's talk about it and what people were doing. And it was kind of a lot of that information came out that people were saying, just use the 1/3. That's reasonable. I have seen it even, written down to as little as 1/10 of a dose. Now that was for tolerance reasons. So also there's some protocols where you mix interferon with the BCG to give it like a boost, and you can use 1/3 BCG with the interferon. I don't remember the exact dose on that. We unfortunately never had really great success with the interferon, and I don't know that it's stood the test of time.
I haven't done that in years, probably now.
Yeah.
With the interferon, but our other, I guess I'm curious to see what everybody else thinks about the alternatives like gemcitabine.
Yeah. We do have a couple people that have chimed in here for us, so I will go ahead and read that for you. So hello everyone, great to be part of this again on a Saturday morning. Love the networking and learning opportunity. Thanks again. That was just from Anonymous. John did chime in with the JW modifier appended to be unused portion on the claim line for BCG. Thanks, John. I knew you would know the answer. Melody Waddington said regarding the 1/3 dose, the vial is so small, I find it difficult to get the exact minimum dose. If I end up not giving the minimum 1/3 dose, I question effectiveness. I find giving half dose with subsequent patients makes me feel the patient is receiving adequate dosing. Now that's interesting. What's your thoughts on, like, would you think a half dose, or I don't know of any studies with half dosing, but
we did do half dosing for a while, at another office, because obviously BCG shortage has been years now. And we did do half dosing and it seemed to work out well. The third dosing, which is one of my providers that came out with, I'm like, it's hard to get, number one, 3 people in at the same time, because it's only good for, I think, 4 hours, if I'm not mistaken. So it's hard to get people in, and then you have to check their urine beforehand. And if they have an infection or they have, symptoms, then you're wasting it anyway. So
yeah, I agree. There could be a lot of issues. John Lynn also said reduce dose BCG for intolerance and scarcity. I agree. Hey, John, you may not have been around when I made the announcement. If you'd like to come on as a panelist, I can promote you to panelist and you could talk live. If you're not set up for that, that's fine. But just send me a question and answer that you would like to be upgraded. I'll be glad to do that. But yeah, I think that BCG would be a great subject for going forward to tackle, to discuss with people what they're doing out there and try to maybe get an audience. Could be a real good after party talk too sometime, if people want to get on and just really kind of hash out what they're doing to get through this craziness, because I don't think these shortages are going away. I think it's going to be a big issue going forward. So,
and we have something now that we just started doing is, I don't know if anybody has experience with the gemcitabine and docetaxel. Have you heard of that, Vic?
I'm sorry. I was reading.
So I was
reading a question about gemcitabine.
So gemcitabine and docetaxel. So apparently, so what we did for this particular patient downtown Chicago, he came to us because he's more local to our office. And he does gemcitabine and docetaxel, which gemcitabine, we have to put it in his bladder for 90 minutes. He stays in the office. And then we followed up with like an infusion of docetaxel. And that's a big thing downtown right now in Chicago. So I was just wondering if anybody had experience with that.
Yeah, I personally don't. The question that we were getting was, in terms of giving gemcitabine, won't you need a chemo certified nurse to give it?
No.
Yeah,
we give it all the time. It's just like BCG. You just have to wear the proper PPE with the chemo, gown, the gloves, mask, things like that. But no.
And I'm not sure it's being, I wouldn't think that this is being done outside of an oncology or urology setting. So we're talking about nurses that should have the training in how to administer these medications.
Now we don't mix it in our office. So we have a pharmacy that mixes it.
Right.
Or, eventually we have another office that's opening and we don't have a pharmacy on the premises. So that's something that you can get from an outside pharmacy, and they can deliver it and it lasts for a lot longer, like BCG. It's a lot longer. It's like, I don't even remember what they said, but that's something we're considering right now, is because once they deliver it, it can sit in storage for, I think, 2 weeks or 4. I honestly don't remember, but it's a lot longer.
So Melanie Waddlington said intravesical administration does not require chemo RN certification. IV administration does require chemo certification. So thanks for clearing that up, Melanie. That's great. All right. I think we may have gotten all of our comments and questions from the audience. So at this point, if there's no other questions, or if you think of something, go ahead and put it in the Q&A. But we're going to switch over to our actual presentations. So we're going to talk about BPH in the office, and Dr. User is going to be presenting on the use of Rezum and Urolift, the two things that we do in our office. And we'll take questions after that. If you think of something while you're listening, feel free to throw it in the Q&A because we'll be discussing after his talk. So let's get Dr. User on now.
Good morning. Today we're going to discuss an update on office urology procedures primarily. And I think the best place to start is BPH. There's a lot of BPH surgery that has moved from the operating room to the office setting. And I'm sure many of you are seeing this primarily with both Urolift and Rezum. I'll discuss both of them, but primarily Rezum. And honestly, because I've done both of them for a while and I have transitioned to being a primarily Rezum physician. And I'll discuss that as to why I feel that way. And I'm not saying that one is better than the other necessarily, but my own personal experience has led me to do more Rezum. So let's get started. And there's a few other office procedures we'll discuss and how we're doing them. So hopefully it'll be somewhat informative. So BPH, obviously, this is just a quick slide to discuss that there are sort of three ways of handling it. There are the conservative measures, and I give all of my patients what I call the bladder irritants diet. And it seems like common sense to most of us, but a lot of patients may not necessarily realize that the 2 pots of coffee they're drinking a day are causing all of these problems. And you'd be surprised how many patients walk away thinking, oh, I didn't realize. And there's some other training issues, but it's primarily the list of things to stay away from. The second line agents I'll talk about in a moment are the medications, which I think are much and overly maligned today. Obviously, there's the office procedures, and missing from that slide are some of the other newer procedures, things like prostate artery embolization, and then there's the new prostatic stent. There's the old school microwave, which I actually still think has a place, and then there's the operative procedure. Now, I just left this slide in, and I'm just going to tell you that I've stolen these slides with permission. The Boston Scientific people were nice enough to give me their slide deck, and I've deleted a lot of the junk that I didn't find useful or redundant. But I love this slide because I get this question all the time from the patients. What about saw palmetto? What about this? What about that? None of them have ever been shown to do anything. I think it's a disservice that what the medicine and the FDA have done to our patients to leave them at the whims of these charlatans that try to convince them with late night Larry King commercials that they should be taking this junk. It's useless. It's all useless. None of it's ever proven to do anything other than placebo. So any of my patients that ask me this, I like to take advantage of the opportunity to besmirch these nonsense therapies that don't do anything. And some of the patients will say, oh, I'm on saw palmetto and it really helps. Well, guess what? That's a placebo effect. And that if they feel that way, I'm not going to talk them out of it. But if they're undecided or trying to decide if they should be taking any of these things, I will tell them that. Now, I will tell them that certain dietary modifications, and I personally am a big believer in plant-based eating and eating lots of soy. There are some studies that show that a high soy diet and a low animal protein diet are good for BPH and prostate size, and actually are related to PSA as well. It's a topic for another day, but if they are going to try to do anything that's non-pharmacologic or non-operative, those dietary recommendations are going to take you a lot further than some bogus supplement. Now, what about the medications? Again, I think that there's a huge push from primarily the Urolift people, but also from the Boston Scientific people. They're sponsoring a lot of these studies and whipping doctors up to telling you how terrible these medications are. And yes, they have side effects. Yes, you have to be careful and aware and take a good history and discuss things with the patients. But I have had patients, including my own father, who have been taking these medications for many years, very safely, very effectively. So alpha blockers are the mainstay of treatment. They work great. There are some issues with retrograde ejaculation. That's very common. And then some orthostatic issues as well. You have to be careful with these little old guys to not knock them over. But a lot of these newer studies that are starting to come out now, I think are very preliminary, and I'm not basing the way I practice based on that. I know there are some physicians out there that have stopped offering medications as a frontline therapy, and honestly, I think that's a bit financially motivated. So I'm not saying that that's that it's a wrong way to practice. It's just not the way I'm practicing. The other biggie that we're using a lot of is still our 5-alpha reductase inhibitors. And obviously for bigger prostates, guys with the PSA over 2.5, they're going to get some benefit. It's not going to do much for the guys with the little prostates. The other way I use these medications is I tell the guys that it'll make their procedure last longer, whatever procedure they have, because it's going to minimize the regrowth of the prostate. So I may take patients after procedures off of alpha blockers, but I'll tell them the 5-alpha reductase inhibitors are going to make it last longer. It's going to, and if you're not having any side effects, you may want to consider staying on it. It's also going to keep the PSA down. I have a lot of patients that have been biopsied 5 times and had the MRI, and then the PSA continues to slowly go up because of prostate growth. And we put them on these, and that's it. It's the end of the endless, cycle of MRIs and biopsies for naught for some of these guys with the really big glands. So I like 5-alpha reductase inhibitors. They're still a big part of my practice. Now let's talk about Rezum and the in-office BPH procedures. And I'll go through this again in a little more detail shortly, but the way I do all of my office procedures, 99% of them, is a combination of a local block and nitrous. And I'll get back to that in a moment. But what is Rezum? Basically, I tell the patients it's like a cysto, and then through the scope, we're going to inject some steam therapy into the prostate. And it works great. The retreatment rates are really low. The side effects are pretty minimal. The first few weeks are brutal. I tell the patients that. I try to manage their expectations and warn them, you're going to get some dysuria and blood and frequency and dysuria, and all of these things are going to definitely be much worse. The first 2 weeks, I make you worse. After that, things slowly improve. By the time we're at 3 or 4 weeks, you should be getting to be slightly better than you were before. And by the time I see them back at their 3-month, they're going to be significantly better. Now, I will tell you that part of the differentiation between UroLift and Rezum is the 90-day global. There is a 90-day global for Rezum. So every one of these visits that you're seeing the patient back for the dysuria and checking pulse voids and such is going to be included in the global. With UroLift, it is not. So that is, again, part of the perhaps the motivation that if you're on the fence and you like both treatments, that may enter into the decision-making process. So let's go through a bit more detail. I'm going to show you this video because I do think it's pretty cool. There's just a few very short videos I'm going to play.
In water vapor or steam. Clinical studies support that Rezum relieves BPH symptoms safely and effectively, eliminating the need for BPH medications, while also preserving sexual function. During each 9-second treatment, sterile water vapor is released throughout the targeted prostate tissue. When the steam contacts the tissue and turns back into water, all the stored energy is released, causing the cells to die. Over time, your body's natural healing response absorbs the dead cells, shrinking the prostate. With the extra tissue removed, the urethra opens, reducing BPH symptoms. Most patients begin to experience symptom relief as soon as 2 weeks, and maximum benefit may occur within 3 months.
All right.
Res-
Going to work out okay for us. So we watched those short videos, and let's just, I'm not going to belabor the point with these studies, but essentially what we're showing you here is that the IPSS scores drop dramatically. The Qmax, how the force of stream works, and quality of life improves. Erectile function is minimally impacted, and really there is no impact. This is probably just the degradation that one would expect with age. Side effects from the Rezum, basically what I've mentioned. Obviously, you can go into retention, clot retention, UTI, and we do see that periodically. You've got to be judicious with leaving the catheter in and how long you leave it in. I personally leave it in for about 3 days, and I will take the catheter out, have the patients take the catheter out themselves at 3 days. Now, if they get a lot of treatments, say 5 or more treatments, then it's going to be longer. If they're in retention when they come in, it's going to be longer. If they're a very elderly, feeble patient that's perhaps in a wheelchair, it's going to be longer. And when I say longer, we're talking somewhere between 1 to 2 weeks. The dysuria is brutal. It's brutal with any of these procedures, but with the Rezum in particular, it is pretty rough for that first week or two. So as long as the patients know, you can give them some Peridium, you can give them some AZO, and that tends to work out pretty well. Here's the reason I really like the Rezum. It's very durable. And this is 4-year data, and I should have mentioned that on the prior slide as well. The 4-year data is now 5-year data that they've published, and through the same study. And basically, the retreatment rates are really good. You're talking about a 4 or 5% surgical retreatment rate, and you're talking about perhaps an additional 5% of medication retreatment rate. Now, like I said, I personally gently encourage a lot of my patients to stay on their 5-alpha reductase inhibitors to maximize this duration that the patients are going to be able to use this procedure, and really any procedure that's ablative. So, laser type procedures or TURP procedures as well. I think that works really well. Putting them back on an alpha blocker, some of the patients are going to need it. Now, some of the time it's because the procedure itself wasn't potent enough, and some of the times it's a patient with a hypotonic bladder and you've opened things up just enough with the Rezum to kind of get them going again, but they may need to stay on both. And sometimes I think it's a little unfair to consider somebody a failure if they're still on the Flomax. Now, if it's somebody who And I have a handful of patients like this that desperately did not want to go to the operating room or couldn't handle a trip to the operating room, but they were in retention, and they had a hypotonic bladder. I think it's a huge success for a patient like that to get them catheter free, post Rezum, but still on sometimes even double dose tamsulosin and finasteride because it's served its purpose. And so I don't think there's any reason to feel like that's necessarily a failure. Obviously, I try to wean everybody off of the that I've done the procedure on, off of alpha blockers especially. And I do succeed the great majority of the time. And some of the patients are on double dose tamsulosin. I keep everybody on their alpha blockers for those first 2-3 months. I don't think there's any reason to take them off sooner. I think there's still a lot of edema and resorption, and they're really not even close to fully healed until you get to be about 3 months out. I really think that there continues to be benefit up to, say, 6 months out, where perhaps the obstructive process is gone and the patients are getting a great stream, but a lot of the irritative symptoms stick around. And the older the patients are, the more irritative symptoms they're going to have, the longer those irritative symptoms are going to persist. So the alpha blockers aren't designed to help with that, but they do help. And that's why I like to keep them on it. And then I'll wean slowly. I'll take them from 2 tamsulosin down to 1. I'll tell them to do that for several weeks, and then down to, say, 1 every other day, and then to stop. Now, if it's anybody with even a marginal post-void residual or a history of retention, I'm going to monitor them as they do that. So I may say, come back in a month, we'll go take you from 2 down to 1, because if for some reason they wean themselves to 0 and their post-void's 300-400 again, you've put yourself behind the 8 ball, and it can be really hard to get those people voiding better again. I think once you develop that sort of chronic retention process, it can be a difficult thing to do. All right, so what are some of the key take-home points with Rezum? It works really well if you've picked the right glands, and I didn't really discuss that in detail, but what are the right glands? I believe it's FDA approved for glands from 30 to 80 grams in size. The really huge glands, neither of these minimally invasive therapies are going to be really good. The treatment is really durable, 4.4% surgical retreatment rate. Sexual function is preserved, which is true for both of the minimally invasive treatments. It works great for patients with the middle lobe, and yes, UroLift is approved for it. I have treated some patients with UroLift with middle lobes. It's got to be the right kind of middle lobe. It's got to be mobile. It has to be big enough that you can sort of swing it off to the side. It's technically difficult. The Rezum is technically a much easier procedure than the UroLift. It's pretty simple to just work your way right up to a middle lobe, put the needle in, blast it. And if it's a big middle lobe, I'll sometimes hit it multiple times. I like to try to hit it for the bigger glands, one on one side, one on the other side. You really don't want to overtreat middle lobes or median lobes, because it's like terping or lasering and fulgurating a bladder neck for too long. That's where the patients get the really nasty, gnarly, long-term irritative dysuria symptoms. So you want to make sure you treat it, but not overtreat it. I also like to sort of hit the middle lobes from the side to some extent. That way, a lot of the vapor energy isn't directed down into the bladder neck. It's ablating the middle lobe itself, just the BPH tissue. Adverse side effects. I have had some patients have some retention, more chronic retention, and even a couple episodes of clot retention. But most of the side effects are just the short-term irritative symptoms. They really do mostly resolve by 3 weeks. I think that they are being honest there. And with the chronic retention patients, I know I've seen this with both UroLift and Rezum, and I don't know why some patients get this. Obviously, the more treatments and the more edema, they are more prone to it. I try to transition these people to intermittent catheterization if possible. But obviously, you got to pick the right patients for that. So let's compare Rezum to medications. And again, this is just to show you that as much as medications are maligned, here's the combo therapy from the MTOP study, alpha blockers plus 5-alpha reductase inhibitors. And it's probably even better for the larger glands. It's pretty close to Rezum. I mean, it's not quite as good, but it is very good. Obviously, you're going to get some disease progression, and they showed that in the MTOP study. And you're not going to get that with any sort of an intervention like Rezum. All right, let's talk briefly about the UroLift. And like I said, it's a great procedure. If you've got a good grasp of it and you've done lots of them, you're going to have more success. It is a little more technically challenging. I started to run into more trouble with my larger glands. These patients would do fine for a year or two. And so as you can see here, there's a pretty decent retreatment rate. This study, they're quoting a 13.6% surgical retreatment rate at 5 years. Now there's the UroLift people are going to dispute that. They've got different studies showing it's a bit lower than that, and it probably is a bit lower than that. But you've got to be really careful with where those tabs end up. I have had a few patients where the tabs are visible and they either need to be clipped or they need to be resected in the operating room. So that's the huge bummer. If you do this procedure and you have a minor complication, you're stuck going to the operating room. Basically, you can't just say, let's just leave it alone. The tabs, if they are in contact with urine, will form stone. So that's what I mean about being technically proficient. You really need to know where to put these tabs, the distance, how much pressure, the angle, to really get the best treatment. Now, there are some guys out there that have done, 1,000 of these. There's a few of them, and they will heavily promote this procedure, saying that it's much better tolerated and the short-term irritative symptoms are better. And I do find that to be the case. The short-term irritative symptoms are present. I do think they are a little bit better. I also think that the catheter rates are lower and shorter. So typically after a UroLift, I will put a catheter in for a day and remove the catheter the next day, unless it's a big bloody mess, which can happen sometimes. At any rate, I don't want to go over this in too much further detail, other than saying that in terms of the anesthesia, I do it the same way. They get a good prostate block. They get a 4-point prostate block at both the base and the apex, and then nitrous in the office setting, and the patients handle it quite well. This procedure is a bit longer. It's a little bit more torquing on the prostate. It's a bit more of a test of your prostate block and the nitrous. So I think you have to warn them of that. The beauty about the Rezum, they're just 9-second treatments, and it's typically 4 to 7 treatments. 4 or 5 is sort of my average, I would say. And so the UroLift is going to be a few minutes longer, a few minutes more discomfort.
All right, thank you. Well, that was great. Just give me a second here. John Lynn, he has agreed to join us for this. Lori, can you unmute yourself? I actually did that to you.
Oh, thank you.
Hey, John, welcome.
Thank you.
For the audience that doesn't know who you are, which is probably most of us here, would you just give us a brief introduction?
My name is John Lin. I am a urologist. I'm a sponge when it comes to information, and I really appreciate the opportunity to jump on kind of unexpected.
Well, that's what these kind of days are good for. I kind of thought that it's a good day to experiment with some other things that we haven't done in the past. So getting a speaker to present for us remotely, we can do that. We've got all sorts of options. And so in the Q&A, folks, is your chance to kind of comment and see what you thought of it. Send any questions you have. You've got 3 experts here willing to answer your questions. But while we're waiting, John, what do you do in your office? What's your preference?
When it comes to BPH, I prefer UroLift. for many, many reasons. And also, of course, medical therapy. And then you have the traditional TURP.
I think it's probably pretty clear that Dr. User's preference is Rezum. And we have, I work with a group of 5 urologists, and you can probably get 5 different opinions as to what the best treatment options are. I think it's like anything else. Whatever you're best at is probably your best option.
That is exactly right.
I think
Lori?
we tried Rezum. I see better outcomes as a nurse with UroLift. And the reason why is because when we did Rezum, they had a catheter for a lot longer than a UroLift. And they had much better outcomes with the UroLift as opposed to the Rezum. I think that as nurses, with the UroLift, I used to see people 2 weeks prior. We used to do a urine to check for infection. We used to go over the bladder irritants, which was huge. We used to give them the expectations that you were going to have like the worst urgency and terrible symptoms. But with the Rezum, I felt like the Rezum, it seemed like it lasted a lot longer.
I think that makes a lot of sense, because with the Rezum, they're going to be a healing process from that burn. And the clips, I don't really think there's much to heal, as far as it's like getting a needle almost. What have you found, John, as far as post-op preferences? Or
I was going to ask Lori, did you mean that UroLift patients had worse irritative symptoms, or Rezum had worse irritative voiding symptoms?
So Rezum did. I think
Okay.
that with Rezum, I think that I gave the expectations to my patients that UroLift or Rezum, either one, are going to have very bad irritative symptoms. But the Rezum, it seemed like, with the UroLift, sometimes, many times, the patient went home without a catheter. Rezum, it seemed like they just kept going into retention. We'd take it out a few days, they'd go into retention. It would go on for weeks. I didn't care for it.
So one of the major reasons I don't Rezum is that it's because I'm very empathetic to the folks, such as my nurses and medical assistants. I don't want you to keep getting those phone calls, the irritative voiding symptom phone calls. Even though you can inform the patients beforehand, educate him, they're still going to call you. And guys, as you all know, hate the catheter. So Rezum, you're guaranteed to have a catheter, whereas UroLift, most of my patients do not need a Foley catheter. And that's one of the major reasons I don't Rezum. It's the irritative voiding symptoms and the need for occasionally prolonged catheterization.
Yeah, that's a good point. I have a different spin on it. I do a lot of ultrasonography of the prostate. So we've had enough patients now where I've seen patients that have had Rezum done years ago. I've had patients that have had TURP, green light laser, and the UroLift. And when you look ultrasonically at a TURP, the so-called gold standard, or green light, you can see this big open defect. And at least visually, it looks great. Whether they're urinating great or not, visually, it looks like they had something done. The same thing when I see a post-op Rezum, you do see that big, like almost a TUR defect. If you're blind to what they had done, you might say, oh, did you have a TURP? Because you'll see that defect. I've never seen that with UroLift. I can see the staples, so I'll notice, almost like when you do radioactive seeds. But I don't know, does it really translate into symptom differences? I'm not sure. Or longevity.
Correct. And that's one of the dilemmas with BPH. You can have, we've all seen older men with huge prostates, and then they're visually obstructive on cystoscopy, but they have minimal to no symptoms. They have no obstruction. They have no retention. How do you explain that? And so when I see these BPH patients, I tell them how I subjectively feel with my finger is very poorly correlated with how you feel when it comes to voiding. The size of your prostate is poorly correlated with how you feel with the way you're voiding.
Yeah, I agree with that. I always describe patients, prostate enlargement is like a donut, because I like donuts. And I said, sometimes you go and you get a donut, a great big donut, isn't a blocking donut. But when you get that donut that you can't get your finger even through the hole, that is inward enlargement. That's causing the symptoms. And
How do you
patients seem to
guys-
be able to.
Just
go
out
ahead.
of curiosity, how do you guys feel about urodynamics before or after a prostate surgery? Sometimes we do it beforehand to look for obstruction. Sometimes we do it afterwards to see if they have an atonic bladder. How do you guys feel about that?
Only if you suspect bladder atony. And even with the atony, a lot of times you can assess whether a man is generating some pressure by asking, are you able to sometimes void on your own? Because a lot of these guys who are self-catheterizing, if they're able to void, then I think, okay, well, you're probably generating some pressure. And I'm more of a minimalist. I don't want to spend, I want to be a guardian of the healthcare dollars. So I don't order a lot of urodynamics. And if anything, Euro cuff may be indicated if you suspect that the bladder is not generating enough pressure.
Yeah, I agree with that.
That'll be a little
Euro cuff.
cheaper.
Mm-hmm. We've done that as an assessment tool, and it's a poor man's urodynamics, I call it. It's not as good, but it does give you some good Well, I mean, the reality is it gives you some information.
Sure.
Is it as accurate as I've done urodynamics for 30 years, so I have a prejudice in what you can read from it, but a good urodynamic person can get a lot of information. But I agree, is everybody need a urodynamics? Absolutely not. I mean, a lot of these guys are coming in now, in their early 60s. They're just having, I'm tired of getting up all night long. They're not having issues with no stream. If they're somebody who's, comes in retention and you're worried about that big, you catheterize them and they're carrying a residual of, 1,000 cc's. Those are the ones you worry, could they have an atonic bladder? And at the very least, I think at least you can tell the patient that, if I do a relieving procedure, whatever it is, you may still not be able to go. That I have doubts because of your condition. I think that's fair for the patient to make that decision, because some, as you said, some with the poor functioning bladder get rid of the obstruction and they're able to empty reasonably.
The other benefit for some of these guys who are self-catheterizing is that when they have a big prostate and they're catheterizing, it's much easier to insert the tip of the catheter into an enlarged prostate. And when you have a deobstructing procedure like a TURP, it's a lot easier, less traumatic. And as you all know, most of these guys are older, sometimes on anticoagulants, and you want to avoid that call. Oh, I stick a catheter in. Now I have hematuria, clot retention. Now I have to go to the operating room and do a declotting procedure. So
it's all about keeping the patient happy, right?
And also keeping him informed of his treatment choices. And that I would, I have switched. I'm one of the guys who have, and looking at the latest AUA guidelines from the American Urologic Association, you can offer medication, but medication you don't have to start the patients on medication as first line as in previous guidelines.
Mm-hmm.
So a lot of my patients don't want to be on medication, especially when they, believe it or not, I have a consent statement that I give to the patient whenever I prescribe a 5-alpha reductase inhibitor. Post-finasteride syndrome, permanent erectile dysfunction, right? You can't donate blood, all right? Potential for increased risk of suicidality, and depression. So those are some of the things that you need to consider, including in your documentation before you start the patient on, for instance, finasteride, which is a generic medication that I frequently prescribe.
Mm-hmm.
Just like their PSA should be doubled after 6 months if they're on finasteride.
It should be what? I'm sorry?
Double, like their PSA, because their PSA is cut in half, right?
Yeah. Well, the other thing is, although it's been shown to potentially decrease the risk of prostate cancer, it is also associated with a slightly increased risk of high-grade prostate cancer. So that is all documented in my note when I prescribe someone a 5-alpha reductase inhibitor.
Yeah. Good information. We do have a question from Melanie Waddlington. We do both Rezum and Urolift. we are finding that a few years after the patient received a UroLift, they are back for a Rezum. Our experience has been that the prostate keeps growing over the UroLift clips and becomes obstructive again. And I have seen that myself too with a few patients that have had the UroLift, that it temporarily works.
I certainly do. I'm one of the guys, the urologist, who has done almost 1,000 of these procedures, and patient selection is key. So you have to be discriminating when you're picking the patient for either a Rezum or a UroLift or any minimally invasive procedure.
Yeah, no, I think that's a key point. You have to have more than, if you're going fishing, you better have more than one lure, because everything's not going to bite on one particular thing. So you have to have more than one treatment.
If you guys if they're saying that UroLift doesn't last as long as Rezum, how long does Rezum seem to last compared to the UroLift?
Well, I think if you look at the studies that they've done, they're essentially around the same. Again, it's depending on the type of patient selection and the skill of the operator. The bottom line is you pick the procedure that works out best in your hands. The retreatment rate for UroLift is about 14% in 5 years. So they're relatively similar.
Yeah.
And a resource for the nurse practitioners and physician assistants who are interested in learning more about UroLift, or the NeoTract, the makers of the UroLift system, hold a BPH summit once in a while. I think they're holding their second one this year, and there's an APP tract that they can really educate you on how to implement patient selection and expectations.
Yeah, that's great. And that may even be something we can look to for UroNurse to bring, is to get a company such as NeoTract to come in and present some of that material for one of our talks. I think that's in my mind. I'm thinking of all the things that we can move forward with UroNurse to be able to provide. And I think that industry, we're not giving contact hours, so we're not in conflict. We can bring anybody we want in to talk. We just want to bring in good quality people to, we want the experts. That's what we're looking for. And sometimes it's industry. So we may be looking at that in the future to bring industry in, along with having a great expert panel is always fantastic. I don't see any other questions here, and by golly, we're hitting that 10 o'clock hour. So at this point, I'm going to go and switch over. Again, thanks to John for being willing to volunteer. Look forward to having you in the future sometime. Pop in here for us. Formally, we'll discuss that. I sent some dates that I had open. I'd love to see if you could fill one of those for me. Lori, always a pleasure to have you on. You've been one of our longest lasting panelists. Andrea was supposed to be here, who's been also here, but had an unfortunate COVID in the family that she had to go cover for, to take care of a family member. So it's going around still, folks. That's for sure. Hope everybody's enjoying it. If there's any questions you have, feel free to submit those later. Otherwise, come join us at our after party. We're going to switch off here and just click that big button that says after party, and we'll see whoever wants to come and hang out. All right. Have a great day, everyone. Have a great, safe Labor Day. Bye-bye.
Thanks,
now.
Vic.
Thanks for having me. Great
Thanks,
forum.
Dr. Lynn.